Jorge Enrique Fajardo Zamudio, a 59-year-old male farmer enrolled in the subsidized healthcare program CISBEN, was admitted on January 25, 2026, with a clinical presentation characterized by epigastric abdominal pain, progressive dysphagia, adenophagia, unintentional weight loss, and episodes of night sweats. The illness began gradually, initially with a mild difficulty swallowing solid foods, which worsened over time until it partially impaired his ability to eat, causing pain upon swallowing and insignificant decrease in appetite. He reported constant weakness, fatigue, and reduced capacity to perform daily activities and work related to his job as a farmer. During his hospitalization, the patient experienced serious medical complications, including septic shock associated with a bacteremia, which required specific medical treatment in the hospital and continuous monitoring. Subsequently, the patient's clinical course was favorable and the inflammatory symptoms resolved. As of today, the patient is awake, conscious, and oriented to person, tolerates the applied healthcare management well, and responds appropriately to stimuli. The patient is being investigated for possible gastric and esophageal neoplasm related to motor dysphagia and esophageal motility disorders. Current diagnoses include abscess of contractile according to the Chicago classifications version 4.0 and basal hypotonia of the lower esophageal sphincter. These conditions prevent the food bolus from passing currently, negatively impacting the patient nutrients and function. In his current situation, he tolerates a semi-liquid diet with the assistance of the speech-language pathology service, experiencing an improvement in swallowing. This led to the removal of the nasogastric tube without severe complications. Regarding this personal history, the patient denies any clinical relevant medical or surgical history prior to the current presentation. His family history includes a significant familial predispositions to cancer, mentioning the death of his mother, uncles, and cousins for cancer. In addition, the patient reports a history of his father's death from a stroke. During the clinical evolution, emotional and psychological disturbance related to the illness and prolonged hospitalizations were evident. The patient present with depression symptoms, sleep disturbances, episodes of sadness, constant worry about his health, and mood swings, all of which have negatively impacted his emotional well-being and a perceived quality of life. The review of symptoms identifies multi-system alterations secondary to physical deconding and overall clinical compromise. Gastrointestinal symptoms included dysphagia, weight loss, and difficulty to adequate nutritional intake. Cardiovascular symptoms include dyspnea and positive diagnosis on auscultation, with a health rate of 80 BMP as a respiratory rate of 39 RPM and oxygen saturation of 93%. Musculoskeletal symptoms included the generalized muscle weakness, although gross range of motion was preserved. Neuromuscular symptoms included impaired transfers and mobility. Functional impairment, increasing the risk of falls psychologically, sleep disturbance, depressive symptoms, and mood change were evident. Among the diagnosis tests performed during the hospital stay, the contrast enhances thoracoabdominal CT scan revealed a calcified nodule in the left anterior parahilar region. The upper gastrointestinal endoscopy revealed erythematous antral gastrophagy, while the pharyngography with cinedeglutition study showed an alteration in the pharyngeal phase due to contrast medium residue in the valequali. The transthoracic echocardiogram revealed mild tricuspid regulation and left ventricular ejection fraction of 49%. Additionally, laboratory tests showed hematological and electrolytic parameters within clinical acceptable limits during the hospital stay. The physiotherapy assessment identifies significant physical deconditioning associated with prolonged hospitalizations and a state of protein energy malnutrition. The patient present with low weight, a body weight of 15 kilograms, and a height of 1.69 meters, consistent with a deficient nutritional status. Moderate fatigue decreases exercise tolerance and generalized muscle weakness in both upper and lower extremities were also observed. Currently, the patients continued under interdisciplinary management and by physicians, physical therapists, nutritionists, and speech therapists, with a focus on functional maintenance, optimizations of respiratory mechanics, preventions of complications associated with a physical deconditioning, and progressive improvement of functional independence and quality of life during their hospital stay.
Thorax semiology, anatomical aspect of the thorax that allow identification of underlying alteration. Facet, functional assessment of therapy for chronic disease fatigue. Inspection observations. Thorax with evident forms of accessory muscles with a shallow breathing pattern. Palpation, slicking the crest thoracic expansion 2 cm. White pain. Auscultation, no pulmonary advention sound and generalizing the crest in breath sounds. Moderate fatigue. Pain McGill, a tool that evaluates the quality and effects component of pain. Stabbing and burning pain, duration of pain high with an increasing intensity at the moment for over 5 referred. Alright in the cervical region and right hypochondrium. Balance Berg scala. The balance scale A56 high rise of falls. Anthropometric characteristic body mass index 55 low weight.
In the muscular performance category, the modified MRC scale was used, which evaluates muscle strength. Took a score from 0 to 5, the patient showed decreased strength in both upper and lower limbs, with greater environment on the left side of the body. Scores between 2 and 4 out of the 5 were identified, especially in the dorsiflexor, hip flexors, and proximal shoulder musculature. These findings indicate generalized physical disconditioning secondary to prolonged hospitalization, fatigue, and compromised nutritional status with limits functional activities such as position change and get self-care. In the anthropometrics characteristics category, the body mass index or BMI was used. The patient had of weight of 50 kilograms and height of 1.69 meters, obtaining an BMI of 17.5, classified as underweight. This finding demonstrates malnutrition and a compromised nutritional status probably associated with dysphagia and the substitution of an oncological process which negatively affects exercise tolerance and muscle mass and functional recovery. In the circulation category, the capillary refill test was performed. The patient present a refill time of less than 2 seconds, indicating inadequate peripheral tissue perfection. Although the result is between normal parameters, continuous monitoring is important due to the patient's cardiovascular history and the septic shock episode experienced during hospitalization. Finally, in the posture category, the postural attitude is meant. In short, sitting was used. Alterations such as ceiling cervical flexion, shoulder protection, hips, and pelvic anteversion were observed. In addition, the patient presents an anterior displacement, the center of gravity, and trunk lateralization on the right. These findings reflect muscle weakness, impaired postural control, and biomechanical compensation secondary to physical disconditioning, increasing the risk of falls and limiting functionality.
Integrity broaden its function and screens told Delsing to present is three of developing pressure ulcers in parents, especially with limited mobility, is which worsens urge set items. Sensory speciality explores mobility, activity and mobility, nutrition, reach out screens lesions, which indicates twin hidden and mainstream nerves. When evaluating in the patient and winning pins is indiscreet is Larry Squares con 17 from impregnating ulcers. Palfer Scale Bartel tiene metuasasa personal autonomy. Things find the ability for basic dealing tasks with assisting. Instructions eating, washing, cleaning, urinating, moving your noun, and walking, rescuing, trashing, dependers, and 100 others independence. Karnowski's performance as clinical scholar is clinical too, that allows the doctor to quantify the patient's capacity in a single number to carry out daily life activity, work, and take care of your work. Yourself. This case in the pain, then the patient and the victim space school, which indicates that he requires work with understanding significant activities.
Intervention: respiratory and ventilatory techniques to improve respiratory functional and prevent pulmonary complications. Modality: braining strategy. Type: inspiratory muscular training. Mode: mechanical. Medium: tertial empty dive. Method: deep breaths against inspiratory resistance. Technique: diaphragmatic inspiratory muscular training. Volume: 3 stiff, a 9, 10 repetition. Dose: 35 of maximum inspiratory pressure with 5 increase base of tolerance. Duration: 22 minutes. Frequency of application: 3 a day. 5 day week. Duration hospitalization. Application procedure: patient set between and 45 and 90 to result in the risk of hospitalization. The threshold in MITI device is placed and the patient is instructed to perform in deep or unsustained inspiratory training. The device overcomes the imposed resistance, followed by slow and controlled respiratory pauses and take beat set to prevention respiratory fatigue and desaturation. Effect in straight into respiratory muscular primary diaphragm, improves lung expansion, increases ventilatory capacity, decreases respiratory fatigue, promotes exercise tolerance, and reduces the risk of respiratory complication associated with dysphagia, aspiration pneumonia, and prolonged immobility. Therapeutic exercise. Modality: street power and muscular endurance training. Type: core stability, muscular strengthening. Mode: progressive assisted active. Medi: static therapeutic exercise on mat. Method: isometric contraction and postural control. Technique: activation and strength of core stabilization muscle. Volume: 2, 3, 6, 9, 10 repetition. Dose: long to moderate intensity according to hemodynamic and respiratory tolerance. Duration: 22. Frequency: 3 and 5 times per week. Duration hospitalization. Procedure: patient sit off supine with head elevated to reduce the risk of aspiration. Activation exercise for the transverse abdominals. Up lower pelvic stabilization muscular are performed using hand isometric contraction, pelvic raise and set postural control. Diaphragm bed in maintain through the exercise. Avoid the valsalva madeurus. Effect: improve lower back and postural stability, proximal control for functional activities, prevents muscular desconditionation associated with prolonged hospitalization, improve balance and exercise tolerance, and contribute to patient therapeutic exercise. Modality: balance training. Type: coordination and motor control training. Mode: segmental coordination exercise with ACE and integration. Technique: coordinate regime exercise and set positive with a hand integration and truck control. Volume: 3 sets of 10 repetition. Duration: 22. Intensity: low to moderate. Frequency: 1 in 2 times per day. Duration: 1 minute. Beat count. Set application procedure. The patient with support and feet on the floor. Constant supervision. Performance direct racer in the different direction from and seat towards network turns. Integration agents hand coordination and trunk control. Slow alternative over live moment are requisite with and control return to starting position. Effect: improve a high coordination and postural control with Seattle, promote with their functional stability and reduce the risk of fall to improve performance in basic activities of daily. exercise. Modality aerobic capacity and physical conditional type early functional aerobic mobility mode active media SIAD exam and supervision short with method progressive low intensive functional activities technical functional aerobic training through early mobilization volume to side of 5 minutes intensive low intensive according to hemodynamic and respiration tolerance duration 20 minutes frequency of application 3 and 5 tips for weekend duration hospitalization application procedure the patient become salir performance activity over and low limb exercise synchronic with control maintenance subjective the progress to Stanley and supervise short walls within the round of hallway according to clinical tolerance vital signals oxygen saturation respiration rate and perceived by fatigue and monitoring during and the activity we activate break types as need to prevent this effect improves the mind of aerobic capacity and functional endurance improve exercise tolerance and prevents physical disconditionation associated with immobility prolonged with hospitalization and history of sepsis.